You have gone on mute, Larry.
We lost the audio.
Okay, now I'm off mute, but someone else has got to get on mute. As a meeting organizer, don't you have the opportunity to mute everyone? Okay, it may have already been done. All right, let's just go ahead and try that again. So lots of opportunities for AI in radiology that I don't have time to discuss today because we're out of time. So we're going to really focus on this area right here, which is essentially dose reduction and scan time.
You're mute again.
Okay, it's off. Nowhere near it. You can hear me again. Right. So as I was about to say, there is, if you would like a syllabus for this presentation to get a feel for, some things that I'm going to say very quickly, you can go to appliedradiology.com and pull this article down that I wrote, if you look carefully, in 2021, full 3 years ago, to give you a sense of how mature this technology is. How that button is, okay, we'll try and keep that button over there. So the first step along this scan time reduction stage is in the area of compressed sensing, right? The creative undersampling of case base that allows you to go faster because you don't have to count as many lines. And you can see the impact of compressed sensing at RadNet facilities here. And this is a lot of Don Baker's work, helped us put this together and roll this out. But you can see at RadNet facilities, we were able to see roughly a 20 to 50% gain in just doing routine brain imaging with compressed sensing. You can see actually on this is from a GE system where we were able to employ compressed sensing for MRI angiography and took error angiograms down exactly in half in terms of the scan time. This again is a Philips slide, which came from RadNet sites when we showed that in the spine using compressed sensing, we had gains that looked like they ranged from about 30 to 50%, which again is pretty impressive. And again, as you'll hear, as it was then with compressed sensing, as it will be going into the future with deep learning reconstruction, you can use these tools in creative ways. You can go fast and say do a quick and dirty scan here, not so dirty, in 38 seconds, or you could sort of accelerate the standard of care down to about 1 minute and 13 seconds, or you can take, an advance over where your scans were before and take all of that scan time for spatial resolution. Now, this is a compressed sense set, but the same principles go really fast, better or a lot better, and trading off some of that speed against quality. And you'll see that across the board. All right. I think no one knows compressed sensing like Philips knows compressed sensing, so let's move on. Let's talk about iterative reconstruction. We know iterative reconstruction from the CT folks. They popularized this. They showed they can use a lot less radiation dose and still get an image. You can do the same type of iterative reconstruction for CT, and there's a company called Medic Vision that actually popularized this way back when. I don't remember when we published this paper, but we essentially looked at accelerating with iterative reconstruction and comparing it against the gold standard, which you see on the left-hand side. And for the brain, we achieved about a 33% scan time. I don't remember when I presented this. I can't tell you how old it is, and I didn't put the time down. But let's just say in this particular trial, we used iterative reconstruction to scan faster on the MR side, and we're able to achieve non-inferiority against the standard of care. When the blue bars meet the red line or come close, that's non-inferiority, and that's what we're able to achieve in the brain, roughly 30% faster. We saw the same thing in the spine. And by the way, this is all done in DICOM space. So this is DICOM-based iterative reconstruction. You see we're able to reduce our scan time roughly 50%, and again, had no trouble meeting non-inferiority. And the same thing in the cervical spine, no trouble meeting non-inferiority. So you can use DICOM-based iterative reconstruction to go faster. All right. Now, we know iterative reconstruction really well from CT, right? It allows us to do images at doses that wouldn't make a diagnostic exam, but now make a high-quality diagnostic exam. Very similar to the MR experiment where you scan less time and can use that signal-starved data to make a better image. It was done first in CT. we've advanced beyond routine iterative reconstruction of CT to deep learning-based image reconstruction over the last few years, with many companies having, including Philips, having a deep learning-based deep learning-based image reconstruction on their systems. You can see the fundamental impact of this on radiation dose right here. This is a standard image in CT imaging. It's called the filtered back projection. The dose index was here at 80. Just think of that as an arbitrary factor. And the noise is measured at 15. You measure it by the standard deviation, right? If I take the dose down to 10%, go to 8.2, the noise goes through the roof, right? You still have the standard reconstruction, but the image starts to look funny, right? See how funny that looks compared to that? That's a combination of noise. That's noise on the image. If I take iterative reconstruction and process this image, I see the same noise index. The noise is still higher than it is here, but lower, and the image changes a bit. We lose a lot of that noise, but we start to appreciate the texture in the image. If we simply take this image here, we take this dose down to 10% here, okay, filtered back, go to deep learning, you see we get an image that looks almost identical. The noise level is almost identical, but we do it with only 10% of the dose. That's the fundamental principle. Now, it has been shown that compared to our standard reconstruction, which was filtered back, and iterative reconstruction, which is what you see here, with deep learning image reconstruction, you get much better noise reduction and much better contrast to noise, none of which is a big surprise. And, coming into the theme we were looking at here, scanning in the factory, you can do thinner slices and make that work. Thinner slices usually means longer scan times in MR, but it usually means much higher radiation doses in CT. But you can see here with a 1 millimeter cut at pedestrian doses, we get an image that frankly exceeds the standard of care. Now, the challenge with traditional iterative reconstruction on CT is that the behavior isn't the same as the filtered back. As you compare to what you'd see with a standard reconstruction where these three different materials all have a collinear behavior, you see there is significant divergence when we use iterative reconstruction. This would be traditional, this would be model-based. We don't see that when we use deep learning-based image reconstruction. As a matter of fact, the Hatfield unit numbers, the quantitative numbers that we relied upon for many, many years with filtered back projection are preserved with deep learning-based image reconstruction, but they're not with traditional iterative reconstruction. As a matter of fact, the biggest complaint we get is the textures change. It just feels funny to us. And you can actually measure that texture change in something called the noise power spectrum. And if you look at these three curves, orange is deep learning, blue is our traditional reconstruction. You see there's a very similar appearance to the behavior with those two, but look at how much different the noise power spectrum is with traditional iterative reconstruction. So it's different, the texture is different. And it is this type of manifestation that you see here, where you have these areas of bright and dark, this sort of cobblestoning to the image. This is in the image, and radiologists object to this. And you don't see that with deep learning image reconstruction on the right-hand side. Now you can see it on these spine images here. There's an overall, like an overlay, almost like a ground glass overlay on this image, which comes from the noise power spectrum shifts from traditional IR. We don't see that with the deep learning IR. And you can see that manifest here as well. Standard image, what a iterative reconstruction image looks like, and what a deep learning image reconstruction looks like. Now, another way to look at this is to apply these things really heavily, and this is our dose star phantom. If we hit it with the heaviest dose of iterative reconstruction and subtract them, you see we're throwing away spatial resolution, right? But if we hit it with a heavy dose of deep learning reconstruction, there's nothing lost in the image. So it's really reassuring. All right, thank you for sitting through CT. It just establishes the principle, radiation versus scan time, and also establishes the principle that quantitative values are preserved with deep learning but lost with other methods. So now you know basically every OEM is either developed or working on deep learning image reconstruction. You know, you've got Smart Speed Out with Precise Image, as we were working on the prototype today. But there also, it comes from the OEMs that you can see here. It also comes from vendor agnostic systems that work in DICOM space, subtle MR and AIRS, although my experience is largely with subtle MR. Just like with CT, maintains the quantitative integrity, incredibly powerful denoising. You actually can preserve or increase the spatial resolution. We will boost the contrast resolution, our ability to see subtle disease, and reduce artifacts. So we'll prove some of that out. You know, it's not just that you can make a prettier picture. This is from Canon, out of a diffusion tensor image, but that the fractional anisotropy values, quantitative measures stay the same. So we're not corrupting our data. So one of the things that radiologists don't really understand is how this actually works. I think you can buy the software and the scans get shorter. It's really not the way it works. You have the power to, so essentially when you have these tools, you can go in, you need to make some manipulations to your actual scan protocol. You can maintain the spatial resolution and just go faster, or increase the spatial resolution to trade off some of your acceleration. The only way you get the acceleration is to reduce the number of averages or maximize the parallel imaging. Essentially, you do everything you can to scan fast at the cost of virtually everything that you hold dear on an image, because the deep learning reconstruction will bring it all back. But if you don't do it, you don't get any acceleration. It makes the images prettier, but you don't go faster. So you want to decrease the number of averages, maximize the parallel imaging, and do things like raising the bandwidth, which trade off image quality enhancements against signal to noise, all put together. And then you say, go ahead, deep learning, take care of it. And that's kind of the way it works. So here you see a nice example where we're able to push the parallel imaging factor to 8. This was done yesterday afternoon, and turn the image to garbage, but mostly just garbage because of the SNR, but no real distressing artifacts in this image here. It's just noisy. And we're able to use deep learning image reconstruction to create an image that frankly is better than the standard of care. Okay, so in reality, the limiting factor is how fast can you scan, how crappy an image can you create, and still restore with deep learning. And those will be the systems that can push the envelope in terms of speed, or a combination of speed and quality. In general, you're going to see, and you're going to see every vendor in the business here. That was Philips, this is GE. Where you turn an image that looks fairly, pedestrian into something that looks sharp and crisp and really has just beautiful definition of lesions, as you see in the spinal cord. That's a GE demo. This is a Fuji demo where you took a routine image and turned it into, frankly, what we expect today, which is a glossy, high curb appeal, high contrast resolution, high spatial resolution, low noise image. This is what we expect today. Now, here's a nice example. This is the standard of care. This is the protocol, would be the same one done at RadNet. When we accelerate, and again, the better the system can destroy images, the faster you're going to be able to go. And I think it's fair to say that nobody's got better expertise at accelerating with parallel imaging than Philips does. So we're able to create this really just awful image, which means I'm going really fast, and I'm able to restore this image to that. Okay, now I don't have the exact scan time. It was something under a minute for this particular scan, and this might have been 2 minutes or 3 minutes, but that's the principle. You see the same thing here. I scanned on a Siemens over in Erlangen. I did everything I could to make the image destroyed. It wasn't as destroyed as this one, by the way, which really tells you how hard I could accelerate, but nevertheless, bad looking image, right? And we're able to restore it to something amazing. Now, what does it mean in a case like this? Really thin slices, which let me see these really small optic neural structures, which is what we're after here. Now, to get a sense of how powerful this is, you can look at this chart, which came from the GE data, where they looked at black being the standard reconstruction, purple being the standard high level of deep learning image reconstruction. The signal to noise at 15 nex is the same as it is at 1 nex with deep learning reconstruction. So roughly 15 repetitions versus 1, which is pretty amazing and a lot different from going from 1.5 to 3T. It also does all of this while maintaining the sharpening. There is no softening to the edges innate to this particular protocol, which is kind of cool. One of the other factors that play into what happens with deep learning reconstruction is the issue of truncation and the use of truncation filters. You see these little parallel lines here you see on this image. That's a truncation effect that's on all medical images. Every vendor has the same issue. They'll use different versions of filtration to get rid of that artifact. And you see, you can actually soften the artifact pretty much using these filters. But you'll also notice if you look at those two images, that one is softer than the other. And the reason why it's softer is part of this process, you lose the edges of K-space where the spatial resolution comes from, right? That's the state of the art. Now, imagine if you could train your model to recognize truncation so that you wouldn't have to use these filters, but your AI would actually reduce the truncation. So you'd get that resolution back. It's kind of a cool thing. Here you see an example from a Fuji system, one of 3 vendors that are bringing this particular market. Siemens is not at the present time. You see the routine image with the truncation filter on. It's a very nice image. It's softer than the one that comes with the AI-based truncation reduction, okay? Because we don't need to use that filter. So in this case, the AI made it sharper, but what we really did was eliminate the need for the truncation filter. You can see that here when we subtract them. This is done with a conventional a truncation filter. This is truncation filter off using AI. Subtracted to, what you see is the ringing what you see here, I'm sorry, is the resolution trade-off. You see all those edges? That's resolution trade-off that you can see when you subtract these 2 images. So using the filter, subtracting it from deep learning, you lose resolution. There it is in that particular picture. And you can see it here when you mag it up a little bit. Now, this is a phantom where truncation is seen as concentric rings around the black dot. You see this white ring around the black dot? That's what truncation looks like. Using deep learning, you can really reduce that effect, right? We can see it on this brain image here where you can see standard clinical practice image looks like that. It's got some residual truncation, and we've probably thrown away some spatial resolution. Using deep learning, it's magical, right? And the resolution goes up. Here you see the same thing from a Fuji. In this case, we turned off the truncation filter here. So we're not giving up the spatial resolution, but we're putting the truncation back in the image, right? Because we didn't do anything to remove it. You can probably see it. It almost looks like the spinal cord is like a mozzarella stick. You have mozzarella sticks over here? Kids eat them, you pull them off in layers. It almost looks like the spinal cord has layers. It doesn't, but it looks like that, and that's what a truncation artifact looks like. And you see when you use deep learning, you get rid of that. But we didn't use the filter here. Zooming in, you can really see a difference between the 2. Now, if you subtract the 2, what you see is all the truncation. All those little ringing lines here that are all the truncation. You see the multiple different edges to the pons and multiple different echoes coming through the cerebellum. So if you can use deep learning to accomplish this truncation reduction, you get this free spatial resolution and you get rid of the truncation artifact, which is kind of cool. And I think that's a really significant sort of what I consider level 2 deep learning reconstruction, where you're aiming, and only 2 other companies have done. You can't do that in DICOM space. You can't do that in on the Siemens system as it currently exists. Now, beyond the 2D, the next step is 3D deep learning reconstruction. Right now on the market, only GE is delivering this, but you're building it into your product as well. And that allows you to just take the same benefits and bring them into things that you do every day in 3D, which are like IECs and dementia brains, things like that. We'll talk about that a little later. But one of the things that everyone does on every system on the market is do a 3D turbo spin echo axial. And without deep learning, you are making compromises. This is an example of a GE system with the routine image and then the deep learning reconstruction image right here. If I zoom in, you can see something very compelling. You see the dark chord, light chord, dark band, light band going through here. You don't see that here. And you'll also notice if I asked you to visually assess which spinal cord is bigger, it looks bigger, right? On the right. It's the same anatomy. That sense of smallness is due to a truncation artifact, okay? And that is something that plagues all of our imaging. So this is a substantial advance when it gets to this next level. So that's a very important thing. Siemens has something very unique. It can't be very unique. Siemens has something unique, meaning they're the only company out with this right now, and that is a deep learning-based interpolation. This is the same image, just with sharp put on. So what Siemens has and no one else has is this very sophisticated interpolation. What everybody but Siemens has is the truncation effect, which again is another way of getting free sharpening by not throwing away resolution. Now, we didn't talk about contrast resolution, but ultimately when you want to be able to see small things or subtle pathology, you need to have contrast resolution. And it doesn't surprise anybody that when you denoise these images massively, you get better contrast resolution, the ability to see some of these small dots. You can look at it this way, no matter what the lesion size is, when you do deep learning reconstruction, you see these things better. This is on a GE, but there's nothing special about the GE in terms of doing this. Anyone's deep learning reconstruction will do this. The next thing is that this is becoming the standard of care. This is no longer, do I trust it? You know, do I believe it? There's lots and lots of literature that point to the validity of this technique. And these papers are several years old. So there's plenty more. We actually did some work in our practice, actually just putting deep learning on our routine images, old way, new way. I don't have enough time to show these to you, except to show you that in every case, the images were better with no particular concern. As a matter of fact, I'll show you the second level of this was, okay, I accept that we can do deep learning reconstruction and that it advances the standard of care. We then went back and said, okay, let's see what we can do about making our standard images match our new expectations. Kind of did the whole expectation in reverse. We're already doing these, and we said, what can we do with traditional reconstruction to try to match it? And you can see we matched it pretty well for spatial resolution, but it's a lot longer and a lot noisier. But you can easily see how this is a spectacular image on the right and offers, lacks nothing compared to what you see here on the left-hand side, which was our emulation of standard of care. Same thing here, patient with a Chiari malformation, the cervical spines were 62% faster. And it's no surprise that in this particular trial, the images with the deep learning were always preferred and easy to review side by side because they didn't look that much different except for the noise level. And as you might imagine, when we scan faster, we had less motion. And interestingly enough, in the interest of purity of science, we always did the deep learning reconstruction last. So this always came first. This always came first, and statistically significant increase in motion because the scans were longer. And that flies in the face of what we know about MR, where if you do multiple averages, you have less likelihood of having motion. Turns out that the difference between 1 minute and 3 minutes blows all of that away, at least at high field. All right, the next horizon is going into non-Cartesian trajectories, right? And this is an area where only one company has this on the market right now. Actually, that's not true. Fuji will, GE does. And motion's a big issue, right? Because it costs us real money. This is one of your favorite investigators, Dr. Jalal Andre, who published this particular work, showing that there's real money and real common, it's really common to have motion artifact. And, you don't want to deal with that when you really just wish you could have that. The nice thing about, having deep learning for this is that you can take these images, which tend to be a little unhappy looking, and turn them into these images, which is really quite nice when you have the ability to go non-Cartesian trajectories. Sometimes we deal with artifacts on our spine images that come from artifacts, really respiratory or cardiac or CSF pulsation that project artifacts into the spinal cord. When we do Cartesian techniques, going to non-Cartesian techniques gets rid of that artifact, and being able to do the denoising gives us that kind of a speed. Now, to get a sense of the impact of these tools in clinical practice, you can see our cumulative scan times across the board, whereas orange is where we were before. These are not marketing slides. Just like the early slides came from our site, these are from our sites where we were before to where we are now on our GE machines. And you can see scan times are under 7 minutes for the most part. Prostate may have a contrast injection. And you can see in terms of neuro, I showed this at the neuro meeting last week to highlight neuro, but you can see the scan times are really in a very reasonable range, running from like 6 to 8 minutes, depending on how many sequences that we actually do. On the Siemens scanner, you actually can see 2 to 3 different versions, whether they have their first version. Siemens came out with something like Smart Speed and then went to Precise. They called it Gain, and then they moved to Boost. So you can actually see both of those effects. But here's what I want you to look at. On their final version, a lumbar spine takes 5 minutes. Okay, a thoracic spine takes 5 minutes. A brain in the ISC with and without contrast takes 15 minutes, which is really kind of a nice thing. So we don't need to belabor that particular point, but just to give you a sense of what we do, and how we do it. This is what a cervical spine looks like at our place, where 2 full cervical spine axials and 3 sagittals takes about 8 minutes at this spatial resolution. Same thing here. Axials from top to bottom, 3 good looking sagittals, all done in less than 7 minutes. Now, again, your ability to go fast is related less to your coils, less to the field strength. It's related to the parallel imaging and your ability to accelerate. And on Siemens systems, we routinely use an acceleration factor of 4. Remember earlier, we showed you the ankle at an acceleration factor of 8. Can't do that on a GE system, right? On a Siemens system, it turns out we've optimized for the spine. It's at a parallel imaging factor of 4, but we're able to get 38 seconds when used to take 3 minutes just, yesterday. Here's just another example of what we routinely generate on a Siemens system. So these are not experiments in this case. This is what we do every day, right? And speed is related to your ability to go fast rather than the ability of anything else on the system. Because everybody can reduce the noise when you build one of these AI systems, but it's about whether or not you can create the noise against speed, which then you can turn into quality and the like. So this is R8, 2 millimeter in this particular case, extending beyond in our dreams to thinner slices, right? So higher acceleration gave us thinner slices, still give us great scan times and net great image quality. And again, this is a strength, parallel imaging factor of 8, for a routine day-to-day ankle and getting images which frankly are better than today's standard of care. Now, again, dreaming with this technology is not common, but I think it will become more and more common once this settles in. There is no innovation in my 35 years in MR, which is almost the entire history of MR, that has not been met with advancing the standard of care. This is the only one where people are just going faster but not dreaming yet. So the dreaming will eventually start, I think, once we sort of get our equilibrium. And one of the examples that you might do is try to do things that are just not practical. You try to take a 1.5 and make it look like a 3T. You may get an image that looks like this. You can see the sharpness. Radiologists like this image. Radiologists like noise. They just do. This salt and pepper feels like quality, okay? But the first thing you notice from this picture is that you've got a lot of salt and pepper, but you can't even tell if there's gray and white matter in the brain here. So you don't realize what you've lost when you starve an image. But you can take the same image and process it with deep learning, and all of a sudden it looks like it's golden. So you can dream 1.5 to 3T. Here, the people from Canon, they dream from 3T to 7T. And again, they get an image that's not, you can't get there from here. Unless, of course, you put that little AI agent on your shoulder and turn that image into that. So dreaming will definitely go on. And I think our ankle is a good example of that. We did some of this today where I actually scanned with a prototype spine coil. Who knows when I did this many, many years ago, and did a 0.9 millimeter slice on a 2D. And it made an image that looked like that. Very high level coil, but still not an acceptable image. The middle image is what happens when you take all the online noise reductions to try to make this work. And RadNet use these all the time. Our scan times that you were looking at were against using noise reduction. Without that, would have been even longer. And you would have had an even bigger delta. But we were very clever. We didn't want to look at noise. And we realized we could go faster with these tools. So we used them. But you can see there are limits to what you can do. And this image didn't create a good, satisfactory image here. Clearly, this is not acceptable. Even though the SNR is not bad. Look at what this image turns into with deep learning-based image reconstruction. It's a 0.9 millimeter image, beyond the standard of care. All right, last piece to talk about in this particular presentation are the folks that are working in DICOM space, right? They're not stuck with any individual vendor, they don't have to be, the vendors in general enable their newest generation machines with these new technologies, but not their older ones. And there's a lot of that out there. RadNet has some 400 scanners and 200 or so are beyond the level of the OEM upgrade. So these tools can actually work for them. But as these tools get more sophisticated, and I'm going to show you significant advances, you start to think about whether or not they have to sit behind the OEM solution, and they could actually go in and fight head to head with the OEM. And they're also bringing out features that the OEM is not likely to do. So there's appeal for those cases as well. But let's just say that for the most part, we're looking at putting this on systems that you can't do this. You can't do the fancy AI-based, OEM-based techniques. And here you just see the same principle. You take an image, you go onto the scanner, you starve it just like you would if you had the OEM solution. All the things you use: reduce the number of necks, maximize parallel imaging, raise the bandwidth, drop the matrix if you want to go faster, raise the matrix if you want to dream a little higher, and then use DICOM-based AI processing to turn this image into that image. Here's some nice cases of alone. These are from UCLA using the subtle medical software. You got a patient with a little stroke. This is the conventional technique. This is the subtle MR of those conventional techniques. And the scan time you see was reduced roughly in half. works, right? So aren't really a mysterious thing at this point. We know here's a patient with an acute stroke. This side took 2 minutes. This flare took 226. This took 148. This took 2 minutes for a gradient echo. This took 90 seconds for a gradient echo. Here's a patient with a bleed. If you look more closely, this took 147. This took 49 seconds. And you'll notice that there's higher SNR, the lesser the grain, a better glossier image in the same time. Now, DICOM techniques can also do things like enhancing resolution. Actually, if you train on a high resolution model, you can actually scan with a low resolution scan, go faster, have higher contrast to noise, but then train that resolution on the softer scan and get this image, in the same scan time. So essentially, we get an image that's sharper than this in roughly half the scan time. You can see that on a 2D sequence as well as a 3D sequence. Here you can see it turned this image into that image, which is pretty impressive. We actually did a trial on this where we looked at 30% acceleration and we compared it against the standard of care. And this was the standard of care scan. This was the lower resolution scan to go faster. But then we used AI to turn this image into that image. So you can see it's a better scan. You can see it's higher spatial resolution. You can see it's higher SNR, but you may not appreciate the contrast to noise piece. If you look in the circle, you don't see a lesion inside this circle. Okay, but if you look at the fast scan with the higher contrast to noise, you see there are 2 lesions here. Okay, and interestingly enough, even though you train the spatial resolution up, you don't lose the contrast resolution. So you get the best of all worlds. This is a paper that we published way back when, I don't know, in 2022, where we actually looked at using the AI acceleration on 3D brain images and wanted to be sure if that it didn't affect our quantitative performance or our clinical standardization. And here you can see this actually won image of the year. It won image of the year, actually, on Ant Mini, because it has pretty colors. But it fundamentally showed from our data that both neither the clinical categorization changed or the quantitative values changed. So you can use these tools, again, another testimonial to that even DICOM-based stuff doesn't change the quantitation. We also published another paper just looking at the same type of DICOM reconstruction showing that we could do 40% faster scanning and exceed the standard of care. This was standard of care here, a little neurogenic lesion. If we accelerate, the image clearly deteriorates. By the way, the radiologists love this salt and pepper, right? I saw some nodding heads. The only difference between this and this and this is scanned 4 times longer. So, it's not filter, it's not an evil, you're smoothing, it's just scan longer, right? So it turns out you don't have to scan longer. You can actually get rid of that noise with AI that you don't have to actually use brute force. So here again, you can see another example. This is the accelerated image. This is the longer scan. The only difference between the salt and pepper and these 2 scans is that this one is scanned longer, so you lose the salt and pepper. Okay, radiologists say, there's a guy online who does cooking, and he uses a lot of profanity. He basically says, don't F it up every time he shows his recipes, and he's yelling at you. And every once in a while, he would get in the face of somebody who says, oh, you're using too much butter. In this case, I'm thinking, oh, it's too smooth, I don't trust it. Okay, well, the reality is the only difference between these 2 is the longer scan. It's not like we're doing anything evil to it. You don't need salt and pepper. It belongs on your steaks. Okay, there's my steak. I cooked this steak. You see, it doesn't belong on your images. So, the old standard of care, the new standard of care, a much better acceleration. You don't need the salt and pepper. This is not quality. Salt and pepper is not quality. This is accelerated, this is standard of care, and this is the new standard of care. If you zoom in, you see really giving up nothing here except for noise. Now, just to give you a sense how real this is, we're doing 43,000 exams per month right now. 43,000 exams per month. So anybody says, well, does cloud technology work? Is it reliable? 43,000 exams per month. That's about 50,000 hours saved per year. All right, so the next step here is the initial algorithms were trained with DICOM on traditional data. But now that we have a lot more of this deep learning data out there, they can train on that data. So now they can start to emulate what the OEMs are doing, and it's pretty amazing what they can do. This is a Siemens Compressed Sense 5, and this is what it looks like with DICOM processing. If you're astonished, you should be, because it's astonishing. Okay, it turns that into that. Now this is GE. This is what it looks like when you accelerate a GE image and you use deep learning, the DICOM-based deep learning reconstruction. Actually, this might be wrong, I think. Yeah, that's right. Okay, so this is I didn't review these slides. This is the accelerated image. This is the new DICOM-based image reconstruction. It looks pretty much like the new stuff, right? Pretty impressive. If you compare that to the GE, this is the GE Air Recon DL. This is the same data with the subtle version 3.0. Yeah, that's exactly right, Gwen. That's exactly what your face should look like. This is maybe better than this. It's pretty impressive. Here's their propeller. You can see what it turns it into. Here's Siemens SWI. You see what that turns that into. It's pretty cool. All right, so that's subtlety. Let's talk about something that's absolutely revolutionary, and that is the ability to take the information built into these images, even in the DICOM space, and synthesize contrast you don't scan. Instead of scanning that, how about we just create it synthetically? And this is not the synthetic MRI that you're working with, with the 3D sequence, with the ability to do like a fingerprint. This is taking a routine on film, essentially T1 and T2, and using the contrast that's built into that, creating an image you didn't create. Now, if you could do this, you could do things like generate an MRA from a routine image, generate a coronal from an axial image. When you have a series fail, like you do here, avoid bringing the patient back by recreating that like that. Reduce the contrast that you need. Take a 10% contrast dose and generate a full contrast dose image. Get 100% time savings by just making a stir from the other images, and again, making a better patient experience. So instead of doing a routine MRA, you can take that MRA from the routine images. This is all works in progress, not necessarily close to market. This one is close to market. A lot of concern about gadolinium in the environment. It turns out if you go for a Coke in Berlin, you not only get fries with that Coke, you get a good solid dose of gadolinium coming from the local water. If you could take a 10% contrast dose image and make it look like a full contrast dose image using this generative AI technique, you would save 90% of the contrast that person is going to release into the water supply. This is a product they're working on, I believe, with Bayer or Bracco. I don't know which one this is. This is actually Multi-Hands. Don't say that I said that. Multi-Hands look like this, and they were able to turn it into that using deep learning reconstruction. Pretty impressive stuff, in my opinion. Here's another one. We have motion and pore enhancement, able to clean up both of them using this generative AI technique, which is pretty damn impressive. Again, I told you you can take a failure. This flare failed. You can make one that didn't fail from the existing data. This flare failed. You can make one that didn't fail from the existing data. This contrast image has motion on it. You can make one that doesn't have motion on it from the existing data. All cool stuff, none of which are very close to market. This has been in front of the FDA for months. The ability to take a routine T1, a routine T2, and instead of scanning the stir, create a stir. Okay, interesting way to put that. But you'll notice that the image is sharper and it has higher SNR because it's made from these, as opposed to all the things that you have to do to make a decent stir, which is lower spatial resolution, longer scan times. So here's osteomyelitis and discitis, all real scans, but you can synthesize this one from the T1 and T2 and potentially avoid that. Now, we published this a little while back, and we showed that essentially the synthetic images performed in a non-inferior fashion against, actually it wasn't non-inferior, it was better. Okay, what it said was diagnostically interchangeable with significantly higher image quality, And here you see some examples. Patient with trauma with posterior paraspinous soft tissue edema. Patient with, again, multiple compression fractures and tissue edema. Here's a patient with a cord lesion, real and synthetic, cord lesion, real and synthetic. Here's, again, osteomyelitis, real and synthetic, real and generated. Bone tumor, real and generated, bone tumor, real and generated. Motion, artifact, much higher SNR across the board for obvious reasons. Less motion, better SNR across the board because it comes from the routine T1s and T2s. Again, much different. The part that's a little more subtle is we have less metal artifact. Okay, this is the real one. This is the synthetic one. Why is that? Because the synthetic comes from the T1s and T2s. When you make a motion suppressed When you make a metal suppressed technique, what do? You bring the bandwidth way up. You can't bring the bandwidth up on a stir because you have so little signal, you've got to go low. So on a stir, you go very low. On the T1s and T2s with all of that signal, you go high. So if we actually reconstruct this image from the high bandwidth images, you get much less artifact, which is kind of cool. And I've already told you that it works better. So if indeed you could make this work, and this is actually from an old system using subtle on a Radnet magnet. You see, we took us about 14 minutes and 19 seconds of gradient time on that system before AI. Using DICOM-based AI, we brought it down to 10 minutes on an old system, not so bad. But if we could eliminate the stir, we could bring that down to 7 minutes. So it's kind of a compelling thing. And again, getting back to that failure piece, you have to stop looking at your watch. If those are messages, because every time you do that, I think I'm running late.
Oh, no.
Okay. I mean, you're right in my eye range. Yeah. I fiddled with my watch once, and I think I just fiddled with it. And the speaker stopped talking, and he said to me, "I'm not late. I'm sitting in the front row. I'm doing fine, because I'm just fiddling with it." Right?
Yeah.
This patient moved. What do you think you could do? Well, you repeat the scan. Repeat the scan. It looks like this. How often does that happen? Most of the time, right? Wouldn't it be nice if you could just do that and get out? Same thing here. This patient moved. Repeat the scan. Moved again. What do you expect? The patient's exhausted. These scans are long. Wouldn't it be nice to just do that? This patient, for whatever reason, the inversion failed. We don't have good CSF signal. We're going to bring him back. Well, we don't have to bring him back. We can do that. So it's kind of a cool thing. We talked about a lot of these things we've gone through. So I think that's a good introduction as to what's out there, where your strengths are, where you will fit once you finish this product, where your current product fits a little bit, where the other people are, and what an absolute fundamental paradigm change this is. It's fair to say that in my 35 or so years in clinical MR, this is the most impactful generational change that I've ever seen. Okay. And it is fundamentally changing everything that we're doing in practice. So any questions on this part before we run through the next presentation, which I'm for? Not a lot of time, but okay, we'll get through the other one pretty fast.
Maybe one question. Is there any place where you're not using it?
It's very funny. I was on a webinar and someone said to me, "What anatomy is this really good for?" And I'm not very reverent when webinar or not. And I said, human anatomy. There is no place we don't use this. Okay, if we're leaning on more 3D techniques, I don't always have that available, but otherwise we use it all the time, and it's 100%. All right, so let's talk about a really interesting opportunity. This is about a half an hour talk. If I take you through the cases, but without the cases, it won't take that long. What's going on? What are the unique opportunities, the important concepts and obligations that we have in radiology in looking at patients with Alzheimer's disease now that we have anti-amyloid therapies? Interestingly enough, there is if you want a syllabus to this presentation, you can look at this article that Dr. Batch and I wrote in Applied Radiology in October of 2023. Why is this such a big opportunity? And I apologize for giving you American data, but 7 million Americans have Alzheimer's disease, and about 25% of them, or 1.5 million, are in the early stages of the disease when these therapies are appropriate and could make a difference. The prevalence of dementia doubles every 5 years after the age of 60, and 1 in 3 seniors will die of dementia. That's more than certain types of cancers and heart disease put together. This is a big population health issue, right? Since 2000, heart disease deaths are increasing, but Alzheimer's disease deaths are going up, aging population. The cost in the US is $3.55 billion in 2021, and it will get above 1.1 trillion, before too long. Now, there are different types of Alzheimer's disease. There's the early onset, which is familial, or the late onset one, which is the one we're really talking about. And risk factors include, age and gender and genetics. There are modifiable risk factors that sound like the things: don't do this. If you read anywhere, don't do these things. Don't do these things. They're really bad for you. And they're making it easier to get Alzheimer's disease. But primarily, there is a genetic risk that's really important. And it's this apoprotein E4 allele that's a problem. This apoprotein, ApoE, has I guess, 3 different alleles. I'm thinking out loud. E3 is the most common, 50% of the population. But if you have one E4 allele, if you have one E4, you have a 25% risk of getting, I'm sorry, I'm getting this wrong because I'm rushing too fast. 25% of the population has one E4 allele, the one you really care about. That triples your risk of Alzheimer's disease. A small percentage of the population has 2, which has a 12% increased risk of Alzheimer's disease. So you could have E2, which is rare and actually protects, or you have either E3, which is in 50% of the population, and you have anywhere between a 3 to 12% increased risk over the E2s. Okay. If you have that ApoE4, which is what we're really looking for, it increases the risk of a lot of different diseases, including amyloid angiopathy, which is really a very similarly related disease. It's almost the same disease in my estimation. They get amyloid deposition in the brain and they don't clear it, right? And it goes to the blood vessel wall. Well, gee, it's the same thing we're going to talk about here. And this is just amyloid angiopathy with inflammation. So there's really no point in singling it out. So the pathophysiology is very interesting. We're always making amyloid. It's a waste product. Ordinarily, people clear it and it doesn't accumulate. But somehow in Alzheimer's disease, there is a disturbance in the equilibrium and you end up accumulating amyloid. Overproduction, underclearance, it's not entirely clear. Once you have the amyloid in the brain, you start to build up tau. It essentially becomes, it creates a circumstance where you get sort of a toxic situation occurring because of the amyloid sitting there. And it just creates a cascade of negative pathophysiologic events, including tau and all the kinds of inflammation and breakdown. It's not a good idea. Tau generally comes in, after the amyloid, and it tends to concentrate in the areas where memory is the most concentrated, right? There are classic metabolic signatures. If you look at metabolic imaging for Alzheimer's disease, this is an FDG PET. You see ordinarily the metabolism is very symmetrical, but you'll notice that the metabolism is markedly reduced posteriorly with FDG PET. Ordinarily, you don't have any tau, but if you have Alzheimer's disease, the tau will be accumulated in the memory structures. And ordinarily, you only see amyloid in the central white matter, but not in the cortex. When the amyloid PET is positive, it's diffusely throughout the entire brain. Here's another clinical case where you've got amyloid extending right out to the surface of the brain into the gray matter, which is an abnormal amyloid PET. And this patient also has tau accumulation in the temporal lobes and the posterior cingulate region. So what's happening now is we have these therapies. These are monoclonal antibodies that attack the amyloid, which is stuck in the brain, and loosen it, okay? And that loosening essentially brings it up into the sewage cycle. Anybody ever walk the streets in Paris at 5 in the morning because you couldn't sleep? And you'll notice they turn on all the fire hydrants and it washes all the dirt down into the sewers. That's what they do every morning. The same thing occurs in your brain. There's always this net bulk motion of water from the periarterial space here. I lost my pointer. From the periarterial space here through the brain tissues to the perivenous space out into the whole body's lymphatic system, this sewage system. So somehow loosening this amyloid gets it up into the circulation. And it moves from the periarterial space all the way through the brain and out. In Alzheimer's disease, it gets stuck. In all patients, it doesn't get stuck. By the way, it's the same thing that happens with gadolinium in the brain. It tends to stick right in the perivascular space until, the linear ones stick and the macrocyclic ones just wash out over time. So does this stuff work? Well, the first drug that hit the market in the US is called lecanemab or Leqembi. They showed that you can actually what did they say? It slowed the rate of cognitive decline. If you look at cognitive decline over time, you'll notice the yellow curve has got a different pitch than the blue curve. So all patients considered it slowed the rate of cognitive decline. If you got them earlier, when their tau was very low, there was no cognitive decline. Okay, and 60% had clinical improvement in that setting. So does it work? Yeah, it slows cognitive decline. If you get it early, it can stop cognitive decline or even improve. So it really points to the effectiveness here. You can actually look at, if you're going to do amyloid PET, you can see that the placebo shows no change, whereas the lecanemab shows it's gone. As a matter of fact, the new drug that Lilly's going to put out, which is, I can't remember the name offhand, it'll show up in a minute. What's that? Donanemab. That one is going to be indexed to the PET scan. When the PET scan is clean, you stop taking the drug. That's how compelling this is. So there are things that are going to change, but that's not important for a quick lecture. But I would say that this is what ASI was predicting. They had about 800 patients on the drug in October. They thought it would hit 10,000 by March. I don't think it hit these numbers, but you have a sense of how it's accelerating. The next drug, as you said, is donanemab, which will be more effective, but probably more toxic. And again, it did a better job when the patients had low tau burden. Here's an example of donanemab. This is a patient that was positive. You see, you don't have gray-white differentiation. This is treated with a placebo and then treated with the drug, and you can see it went from staining the entire brain to only in the white matter. All right. So, more importantly, as an imaging company, if you want to get on this drug, you need to prove that you have amyloid. It is required. You could do this with a CSF test or lumbar puncture, a blood test or a lumbar puncture. This is all people had, so they were using this, but now that PET is available, those scans are going down and PET is taking over. What happened with PET? Well, they used to have a rule that said, we're not covering this, and in a clinical trial, we'll cover one for your whole lifetime. Both of those rules are gone, and payment is coming in. Coming around January, payment started. This is the RadNet amyloid PET volume from May 2023 to April 2024. Every one of these patients who has a positive scan gets into the MR pipeline. So this is just starting. January. This is January. Look at that. It's probably more than we did the entire year beforehand in 1 month. And then look at this. Yeah. I don't know. The reimbursement is enough to pay the bill. You know, you'll have a 20% copay that, you know, at Medicare. It's probably several $1,000s. Okay. It's reasonably accessible. And then once the money comes, everybody will find a way to do it. I think there may not be enough PET scan, but they only need one. They only need one. They might end up getting more than one if they want to use it for surveillance. I don't think access is a major issue in the first world. Okay. When you think of MR and Alzheimer's disease, we typically only did MR to exclude what we would call treatable causes. Patient's got a big meningioma or has hydrocephalus. Okay. The next level of sophistication was we would do a quantitative brain assessment to look for some of the hallmark anatomical changes that might point you to a certain type of dementia. And that's where these color-coded segmented images come into play, and you try to make early identification. It turns out that you can do a differential diagnosis to what's causing the patient's cognitive impairment by the pattern of atrophy. And you can see the typical patterns. In Alzheimer's disease, there will be atrophy involving the hippocampi and temporal lobes. With frontotemporal dementia, it'll be the frontal and temporal lobes. In vascular dementia, you don't see much in terms of compelling atrophy, but you see a lot of white matter lesions. And the other major category, which is the Lewy body dementia, doesn't really have classic atrophic findings. If you look at something like your icometrics partners images, they render these things with kind of a nomogram that make it easy to see at a glance what you're looking at. When the black curve is in the middle, that's at the highest percentiles in terms of volume. When it starts to point in a direction, it's pointing in the direction of volume loss. So you'll notice in Alzheimer's disease, it points towards the hippocampus, parietal lobe, and temporal lobe. So really is a glance, you go, oh, that's an Alzheimer's case, right? Whereas in frontotemporal dementia, it points to the frontal and temporal lobes. They're down to the first percentile. That's the way that works. And even more importantly, it's impossible to see incremental change when there's volume loss. But if you were going to use a tool like continuous volumetric assessment during therapy, you would want to be able to look for incremental change to follow improvement.
Quick note, because I see we are out of time.
Right.
Suppose we take 5 or 10 minutes so you can continue and cover that properly.
Yes.
This is recorded. If people need to go because we have a meeting, feel free to go also online. This will be recorded and then we can take another 5-10 minutes.
Okay, great. It isn't going to take much more than that. Here's a very nice case I'd like to show you. The patient was seen in 2009. You can probably see some atrophy here. They had a PET scan which showed temporal lobe hypometabolism. So it looked like an Alzheimer's case, but there were no therapies, right? 2016, the patient came back worse. You can see the volume loss is worse. We'll take a look at the quantitative imaging here. You can see that it's really fairly striking with the volume loss, hippocampi, parietal lobe, temporal lobe, really at the worst levels. And you see the amyloid PET just staining the entire brain. So a classic Alzheimer's disease. Now, the difference in 2024 with these therapies, the role of MR has changed from ruling out surgical causes to maybe giving us a hint into what type of dementia. And now we have a distinct role. This drug causes inflammation in the blood vessel wall. Okay. And therefore, you need to be vigilant about the complications of leaking blood vessels, including a predisposition to bleeding. So one of the things you must do now with an MR, have an MR before you start therapy that looks for things that make you bleed, prior bleeding, strokes, or vascular lesions required, right? These are the type of things that you would expect to see. I think I skipped one. The type of things you look for, anything that looks like blood in the brain or a tendency to bleed. I won't read you through all of these, but amyloid angiopathy is one, and that's an example of amyloid angiopathy. I'm just going to bring this down so the folks can see that here. All right. So when we give this drug, it causes the amyloid to be mobilized. Mobilized amyloid causes inflammation. The inflammation tends to center itself early on in the vessel wall. We have to survey for these complications, and these complications are referred to as ARIA, amyloid-related imaging abnormalities. It really is amyloid inflammation, amyloid mobilization-related inflammation, and vasculitis, right? But they haven't changed the name of it, just referring to the amyloid as ARIA. So I showed you what happened in RadNet when the PET scans could get reimbursed. I also told you that the PET scan is the gateway towards this process. If the PET scan is positive, you can get on this drug. So just about January, the PET scan started to click in. Look what's happened to our brain volume. We've gone from where it was before in January of the average around 21,000, almost 22,000, 23,000, 24,000. This is again in the earliest stages of the PET gateway being open. This is going to continue to rise, and it's not going to be unique to us. Okay, you're going to see brain volumes go up. Now, I explained that with this, you're going to get inflammation, right? You're going to get, the inflammation can be seen as water leaking through the vessel wall, which can end up in the brain or on the brain. So inflammation, water in the brain or on the brain, edema in the brain or on the brain. In the brain looks like a white matter lesion, on the brain, which looks like a sulcal effusion as well. You also can get hemorrhage in the brain or on the brain. In the brain, it looks like a microhemorrhage. On the brain, it looks like siderosis, and we'll talk about that. This is actually a micrograph, and green is actually amyloid. And you can see amyloid in the brain parenchyma. You can also see amyloid in the vessel wall, which should be red. All right, so it can look like edema in the brain, edema on the brain. It can look like hemorrhage in the brain or hemorrhage on the brain. Let's look at some examples. So what you see here is an example of ARIA-E, but this is actually in the a sulcal effusion. And you see the white arrow is pointing to the fact that these sulci, these few, are actually bright, whereas the rest of the sulci are actually dark. This is a patient with ARIA in the brain, ARIA-E, on both sides. You see over the course of several months it resolved, and almost all ARIA resolves without symptomatology. Here's a patient that had no hemorrhages prior to treatment, but then ended up with looks like 10 or so microhemorrhages after treatment. These little black dots that you see here on MR look very much like these little black dots you see here on this cadaver specimen. That's what it looks like in clinical practice. So you have microhemorrhages. You also have what's referred to as bleeding on the surface of the brain, which we call superficial siderosis. Siderosis is hemosiderin deposition, right? So and that looks like dark signal, which parallels the sulcus. So edema in the sulci, or edema in the brain, hemorrhage in the brain, little tiny punctate, or hemorrhage on the brain. All right, some examples. This is a patient who was on the baseline, had no contraindications, no evidence of any problem. Patient was treated, developed this small area of edema, and that little tiny microhemorrhage. It's expected. There's a certain percentage of patients will get this. This patient was asymptomatic. They were continued on therapy. The second visit, you see there's 3 hemorrhages and a little larger area of edema. This might lead to a cessation of therapy, temporary cessation. We'll talk about the rules in a minute. This is a RadNet case. Patient had 79 years old, thought to be early onset dementia, was getting an MR screen for Leqembi, some mild white matter lesions, nothing to write home about. When you did SWI, we actually noticed that there were 2 areas of hemorrhage in the brain, in the red circles. Okay. So not a contraindication. Only 2 little microhemorrhages. The brain looked pretty good. Patient had volumetric imaging, with frankly the wrong company, and it didn't show much. Matter of fact, the radiologist read this as normal because the occipital lobes, temporal lobes, all looked. The temporal lobes looked normal. They had they were normal volumes. But the radiologist missed the fact that one of the favorite areas where the tau tends to accumulate, the posterior cingulate region, was at the 2nd percentile. Didn't even comment on it in this particular case. So this patient, early onset dementia, no real volumetric assessment except for that. Kind of interesting. Put on therapy. This is what they looked like before therapy. This is what they looked like after therapy. What do you see here? A large area of edema in the brain, or RAE, right? This was a routine surveillance exam. Patient was not symptomatic. And I'll talk to you about what kind of surveillance has to be done, which impacts your MR business, but asymptomatic has this particular finding. If you look at the follow-up exam, after therapy was halted, patient came back and it was resolved and therapy was able to resume. If you take a close look at the MR, though, there was a new area of hemorrhage with this area of edema. So they went from 3 hemorrhages to 4. All right, so this ARIA that I've shown you, it occurs in roughly 37% of patients who are getting donanemab and a lower percentage of the ones that are getting Leqembi or lecanemab. Symptomatic levels are very, very uncommon, only 6 or 3%, basically. The majority of these events are mild and self-limited. Bad things have happened, particularly in cases where they kept them on, where they didn't monitor properly for the complications, but it's just not common. And the risk of getting ARIA is, again, going to be related to those ApoE4 alleles, right? Not only is your risk of Alzheimer's disease goes up, your risk of amyloid angiopathy goes up, but your risk of ARIA goes up. Because again, it makes sense that you have a higher load of this inflammatory substance. So this is the way RadNet deals with this stuff. We have this workflow for our schedulers. So you come in, you get this, you get that, you prove you got amyloid. If you have amyloid, then you get your MR, you get your screening MR, you get your infusions, and then you get a series of MRs over time to monitor for complications. We actually have a special protocol that says brain dementia baseline, brain for ARIA surveillance, and then whether you want to add a quantitative T1 to those cases. Here's the big bang for the buck. You get a pre-treatment scan and then another scan at the 5th infusion, the 7th infusion, and the 14th infusion. That's 5 scans in 6 months. If you have a headache, you get another scan. Okay. If you have a seizure, you get another scan. If you have ARIA and we have to stop therapy and wait to start it again for it to resolve, you get another scan. So for every one of those 1.5 million people, you're going to get somewhere between 5 and 10 scans per year. Do the math. All right, so what we do for our scans, the only unique thing that we need is that you have a challenged patient population. So if you build a system that's first time right, you're going to have a better way to go. If you build a system that adapts to a challenged, somewhat nervous and anxious patient population, you're going to do a better job. But otherwise, it's a routine study. We like to do the Alzheimer's study group from the AJNR, from the ASNR, recommended that if you're going to do a T1, might as well do a quantitation capable T1 so that you could theoretically use these quantitative tools to track progression, and a traditional gradient echo, because your sensitivity to hemorrhage matters. The clinical trials were done with this more primitive technique, but that's what the science is based on. So you can be more sensitive with an SWI, but you don't have any scientific basis for making decisions on the SWI. For the technical folks, the biggest mistake that I see out there is the TE is wrong on these gradient echoes. And the reason why the TE is wrong is because over the course of time, a lot of good-natured people figured out you can go faster if you bring the TE down. And yeah, they're faster, but they're useless. You can't see anything. Okay, on a 1.5, it should be somewhere around 30, 25 to 30. On a 3T, it should be somewhere around 20, 15 to 20. If it's not, if you don't see artifact on the image, you're not going to see hemorrhage. That's the basic rule. Now, these are the rules. You see, the rules have changed. We have gone from, okay, yeah, we don't see anything to treat surgically, to we have a distinct and important obligation to both detect and quantify ARIA, because decisions will be changed based on what we find. Detect and quantify ARIA. So if you need to detect the presence of siderosis, microbleeds, and edema or effusions, and you need to categorize those as either mild, moderate, or severe. And these are the rules. 1 area of siderosis is considered mild, 2 is considered moderate, more than 2 is considered severe. Microbleeds less than or equal to 4 is mild, 5 to 9 is moderate, 10 plus is severe.
Size doesn't matter.
Size does not matter. Microbleeds. Size doesn't matter. Size does matter for the edema. So mild is unifocal, 1 or less than 5 centimeters. Moderate is more than 1 site or 5 to 10 centimeters. A macro bleed, by the way, if you have a macro bleed, you stop treatment regardless, forever. Okay, so these are really micro bleeds and more than 10 centimeters. So again, when it comes to ARIA-E, you would continue dosing if the symptoms are mild, or you have, if the findings are mild and you don't have symptoms, right? Or don't have symptoms, but you would suspend therapy if it becomes moderate to severe, and you suspend until the findings resolve and the symptoms resolve. That's from ARIA-E. For ARIA-H, you suspend therapy if it's moderate or severe, but you can continue therapy if it's mild. So if you pick up 1 or 2 microbleeds, 1 focus is siderosis, it's not a problem. All right, let's do some cases. What do you see here? Pre-treatment, post-treatment. Everybody sees a red circle. What's in the red circle? A small area of edema, right? What do the rules say? If it's less than 5 centimeters and it's 1, it's mild, so you can continue therapy. These are the obligations that the radiologist needs to understand, right? Here's a patient that went from nothing, basically some white matter lesions, to 3 new areas of edema. All right, what do the rules say? Multifocal. Multifocal needs to suspend therapy until these resolve. Here's a patient that has a little bit of edema and only 4 hemorrhages. This still categorizes as mild, so you can continue that treatment, right? Whereas here's a patient that has no hemorrhages, now has at least 5. What does that mean? For the hemorrhages, they don't go away. So what you do when you do surveillance for hemorrhages is you stop treatment and make sure that it's stable. This patient doesn't show bleeding. A month later, you go back and put them back on therapy again. And that's an important piece. And again, this person you had to suspend. All right. Here's the problem. Radiologists are really bad at picking up ARIA. They're really bad. Remarkably bad. Shockingly bad. Part of that is the findings are subtle. We're not used to looking for this. And the other problem is that to do this right, and you can see up to 84% of ARIA findings can be missed in published literature. Okay. It's a big deal. So the problem here is that your quantification needs to be standardized and consistent, and your detection needs to be accurate. So it's awfully nice to be able to have an AI-based tool. And there are a couple of these coming to market, but the one that's going to have the highest degree of academic imprimatur is the one that was trained on the Biogen ARIA data, which is the icometrics tool from your individual partner. In this particular trial, using real data against the AI, using real radiologists, emulating the community setting, they were able to show that their performance was really quite a bit better. Here's a nice example of the AI detecting, matching the radiologist's sense that there is ARIA-E here. And here's one, again, another one where we really matched the radiologist's sense. Here's an area of siderosis that developed over the 2 scase, and the algorithm said, I see it very nicely. And here's one, I think, where the radiologist matched that one. I think I was going to show you the failures in a minute. But the bottom line is, in this trial, the radiologist missed roughly 30% of the edema cases and 31% of the hemorrhage cases. The performance improved significantly when you added the AI to the radiologist in terms of sensitivity and specificity, and particularly helpful in the milder cases. Now, here's where the failures come in. Here's a case where the radiologist didn't see that, but the AI did. Okay. Here's another one where the radiologist didn't see the change. It doesn't look like much. Your radiologist is going to walk right by that. Oh, yeah, there's a bunch of white matter lesions. We see those all the time. Didn't notice that a couple of them were new, but the AI did. Same thing here. Radiologist didn't detect the hemorrhage here. The AI did. Actually, in this particular case, I believe the AI overcalled the hemorrhage. And excuse me, the radiologist overcalled the hemorrhage, but the AI didn't agree. Only saw one. I maybe saw the other one here. Didn't see that one. Radiologist read, AI read. Sorry, I haven't looked at these slides in a while. Here's another one again where the I don't think I meant to show you that one. So let's get back to the point at hand. The performance of the two together better than the radiologist alone across the board with statistical significance. And more importantly, if you look at the unassisted reading versus the assisted reading, and remember, if you shift from this category to one of these two, this category to one of these two, you change therapy. Look what happens to those curves when you add an AI. Any shift to the right is a shift in change in treatment. So without this tool, there's going to be inappropriate treatment. And that really is the key piece here to go on. So that was a quick and dirty run through this without a lot of prep because I haven't looked at this lecture in a month or so. But a sense of the opportunities in terms of volume, in terms of the obligations, in terms of using MR to detect and prevent further complications from this groundbreaking therapy. And let's just say that there is one drug available, the other drug is imminent, and there are more in the pipeline. The more aggressive drugs are going to have higher complication rates. If we continue to follow these patients appropriately, stop therapy appropriately, prevent complications, those more aggressive medications will probably cure more people and do really well. But look at the volumes. Imagine that somewhere in the vicinity of 15 million more brain MRs per year. What would that mean in terms of utilization, in terms of new scanner purchases, in terms of people needing to buy, their precise upgrades so that they can get, one more patient done per hour per day or two more patients per hour per day. It is, again, one of the most compelling volume opportunities in MR, coupled beautifully with one of the most compelling tools that make your scanners more capable and able to answer that need. So very exciting opportunity. Again, in both cases, if you want to get a really good sense of this, I showed you two articles. Both have Dr. Bash's name and mine on it, right? The one on deep learning reconstruction, you could probably suspect was primarily written by me. The one on imaging of dementia, where Susie does a lot of this work. I'm a technical guy. She does a lot of this work clinically. Was written mostly by her, but just like Lennon and McCartney, you never know. That's a secret. You only find out after we're dead. So, but it's a very nice piece. It will give you the same type of information, some good documentation, things you can refer back to. And again, just type into applied radiology, my name, her name. You'll find all those articles easy to download. Questions? Anybody?
Well, thank you so much, President. Thank you. Is there one or two questions on that topic? So do you foresee that for this treatment you will apply dedicated systems?
That's an interesting question. I don't know the answer to that. I would suggest that the economics today are so strained that you would first try to squeeze everything you can over your existing install base by buying upgrades. The US market is a very low margin market, right? It's hard to make money in MR unless you're really good at your business, which is why you're seeing so much consolidation. And then why you see all the private equity places fail as well, because medical imaging is no place for private equity. There's no margin for them. So, there's no margin, there's no dividends. It's a tough market. So I would say, I wouldn't advise anybody to go put a scanner in. Interestingly, Hyperfine is supporting a trial that said, we'll just take the scanner, roll it into the infusion clinics, and maybe we'll find a role for this. I said, what about the hemorrhage? Well, we're hoping that we can find an algorithm that won't be dependent on the hemorrhage. So like if we see edema, then we'll send you to look for a hemorrhage. Now, so can you prove that you'll never see hemorrhage without edema? Or you'll never make a treatment change without edema? They may be able to come up with a paradigm that says that, but the traditional approach requires detecting the hemorrhage, and they're not going to do that at 0.064. So maybe in certain parts of the world, it's an access issue. You send a low field system in. But I would say that I don't know whether entrepreneurs will jump in. I would think that we would suck all the volume out of all the systems that we have. On the other hand, you've seen in the last 3 months at least a 20% boost in volume of our brain MRs. And that's just in the first 3 months of amyloid being available. That will eventually plateau, where the supply will equal, and then we'll have a feel for whether our systems can handle the MR volume. But the more aggressive the drugs are, the higher the ARIA are, the higher the percentage of those people are going to go from a required 4 scans or 5 scans into 10 scans. There is no reimbursement barrier to the MRs, just seen as routine MRs, and there is no reimbursement barrier to at least one PET. Some people will actually use PET to do surveillance. And as I mentioned with the donanemab, you actually have to use PET to do surveillance because it was required. You have to, when the amyloid is gone, you stop treating. So imagine how many PET scans they're going to get, what that algorithm will be when that comes out. We haven't seen the package insert, but they may say things like, at the end of 6 months, do a PET, and then at the end of 6 months, do another PET. I don't know that, but we'll see what the FDA and the manufacturer work out. There is a suspicion that the ARIA complications are much more common than the clinical trials showed. Partly because they were using human eyes for the AI, right? Instead of AI. So if indeed the complications are higher, that means the more scans are going to be higher. You know what I mean? That means they're going to see more scanning. If we have a tool that says, hey, you're going to get another scan. So
UI at some point.
yeah, if you do that, but someone's got to prove the science on that, and there was no impending science to prove that. So I don't think that's going to happen. But if you did, it would be a problem. So let's give an example why I don't recommend SWI, and people who do I think are irresponsible. You got 3 hemorrhages. Now you see a 4th on SWI. What are you going to do? There's no rules for that. If you stop the therapy, you're now stopping therapy on someone who there's no science that says you should. Why? Because it feels good, or you have this new technique that can show you something else. There's no science behind it. The science and outcomes are based on what you can see with a gradient echo. So one of the guys was at the ASR meeting saying, I'm using SWI and I encourage you to do it. To me, that's just inanity. It just makes no sense. So while they chose GRE because everybody didn't have SWI, the science is based on GRE. Unless you relook at the numbers for the cases that had SWI, you can't use SWI. Now you say, well, let's just do both. Well, if you do both, now you've got another problem. You've got to read both scans. And then you have to figure out what you're going to say when you've got a discrepancy, which is going to take even longer. And then some lawyer is going to find that discrepancy in your reports and then challenge you. Why didn't you stop treating this patient? Well, because you saw the extra. Well, it becomes a real quandary. So the lawyers will like it, and you won't like it. So the best thing to do is just stick to the routine gradient echo until the science changes. But it's only been 3 months. You saw the volumes.
Thank you so much.
You're welcome.
We need to